in last class we were on the myasthenia gravis, and already this topic has been covered, but to do a quick revision, what's myasthenia gravis, how it can be differentiated with other condition, that is the cholinergic crisis. Myasthenia gravis and the cholinergic crisis have the same clinical manifestation, that is the muscle paralysis and the muscle weakness, but however the pathophysiology is different, or the causative factors for both this condition, myasthenia gravis and cholinergic crisis, are different. So how can you differentiate whether the condition is myasthenia gravis or it is a cholinergic crisis? So for that we give the shortest acting reversible acetylcholinesterase inhibitors. So that is the idurfonium. It is the shortest acting reversible acetylcholinesterase inhibitors. Someone is sharing their video. Can you please stop sharing your video? So for this, idurfonium is given that in the dose of 2 milligram, and as said earlier, the pathophysiology of two conditions are different, that is the myasthenia gravis and the cholinergic crisis. So myasthenia gravis or myasthenia crisis, which is the same condition, it occurs as a result of destruction of the NM receptors, since it is an autoimmune disease, and there is a destruction of NM receptors due to formation of autoantibodies against it. So the released acetylcholine cannot act with adequate number of NM receptors, and as a result there is a decrease in muscle contraction, skeletal muscle contraction, which can result in the weakness and muscle paralysis, skeletal muscle paralysis. Whereas the other condition, cholinergic crisis, the outcome is the same, the consequence is the same, that is the muscle weakness and the paralysis. However, the positive factors is different. So coming to its positive factor or the pathophysiology, so it occurs as a result when there is excess of cholinesterase inhibitors, when they are given in higher doses or when they are given for a prolonged period of time. So what does it do? It inhibits the metabolism of acetylcholinesterase. You know, acetylcholinesterase is responsible for degradation of the acetylcholine. So when these drugs inhibit this enzyme, so acetylcholinesterase enzyme, so acetylcholine won't be metabolized, won't be degraded, so there will be increased level of the acetylcholine. So this now increased level of acetylcholine will increase, obviously will stimulate the NM receptors on the skeletal muscle and will increase the muscle contraction. But on long term, so increase in muscle contraction, skeletal muscle contraction will subsequently lead to placid paralysis and relaxation of the skeletal muscle. So the outcome is same. So why we give idurfonium to diagnose this? The condition is myasthenia gravis, the cholinergic crisis. So you know the mechanism of action of idurfonium. So idurfonium is acetylcholinesterase inhibitor, very short-acting acetylcholinesterase inhibitor. So now this will inhibit this acetylcholinesterase enzyme. So that means it will increase the level of acetylcholine because it has inhibited this acetylcholinesterase enzyme that is responsible for degradation metabolism. So there won't be degradation of the acetylcholine and there will be increased level of the acetylcholine. And now increased level of acetylcholine when the idurfonium is given occurs, and this results in the increase in muscles that are present on the skeletal muscle and plate or neuromuscular junction. So there is two conditions, myasthenia gravis and cholinergic crisis. So when you give idurfonium, there is increase in skeletal muscle contraction. So in myasthenia gravis, there is decrease in skeletal muscle contraction. So when you are giving idurfonium, since it increases skeletal muscle contraction in myasthenia gravis, it has been decreased. So it will improve the condition. So myasthenia gravis is associated with decrease in muscle contraction. By giving idurfonium, the skeletal muscle contraction increases, or there will be the improvement of the condition. Whereas in cholinergic crisis, there is already increase in acetylcholine level. So you are giving here idurfonium, then you are exaggerating the increase in acetylcholine level. So you are exaggerating the condition. That means when you give this idurfonium in this cholinergic crisis, there will be no improvement or there will be the worsening of the symptoms because both conditions have increased the level of the acetylcholine. So here in cholinergic crisis, there will be no improvement or there will be the worsening of the symptoms. So you can diagnose either the case is myasthenia gravis or the cholinergic crisis by giving the idurofonium, which is the shortest acting reversible anticholinesterase inhibitors. And for this 2 mg idurofonium is given intravenously. So to confirm myasthenia gravis, so while giving idurofonium, if there is a reversal of the weakness, muscle weakness, skeletal muscle weakness, and if there is short-lasting improvement in the strength of the affected muscles, so the condition will be myasthenia gravis. And if there is no improvement or if there is a worsening of the symptoms, then it will be the condition will be the cholinergic crisis. So we were on the uses of this reversible anticholinesterase. So, it is used in glaucoma, in the treatment of the glaucoma, and for that pilocarpine is used, and pyridostigmine can be given as additive drug, adjunctive drug to supplement pilocarpine. And we read about the myasthenia gravis, and here neostigmine is the drug of choice. So apart from the neostigmine in the use of treatment of myasthenia gravis, other drugs like corticosteroids or immunosuppressants, similarly plasmapheresis can be conducted, similarly thymectomy can be conducted. So we are going through the uses of reversible anticholinesterase. And coming to the other uses of this reversible anticholinesterase inhibitors, reversible cholinesterase inhibitors or anticholinesterases, so they are given the poisoning or when there is overdose of anticholinergic drug. So this prototype drug of anticholinergic drug is the atropine, which is also known as the belladonna. So as said earlier, here physostigmine is given. So why physostigmine is given? Because it's tertiary ammonium compound, can cross the blood-brain barrier and can reverse the so atropine is tertiary ammonium compound. It can cause a drug is required which can cross the blood-brain barrier and reverse the CNS manifestation that is caused by the atropine, and for that the physostigmine is given. So please don't try if the option is being given like which of the following drug is the drug of choice in the atropine poisoning, and the option is like physostigmine, neostigmine, pyridostigmine or idurofonium. So the answer should be the physostigmine. So neostigmine, pyridostigmine cannot be used because they all are the quaternary ammonium compound and cannot cross the blood-brain barrier. And again, they can be given in case of post-operative paralytic ileus and urinary retention, and for this neostigmine is given. So post-operative paralytic ileus and urinary retention usually occurs after the post-surgical procedures or after the operative procedures after the operation. So usually this post-operative phase is accompanied by the constipation, so which is known as the paralytic ileus, ileum, or the large or both the large as well as small intestine has been paralyzed and cannot urinate. So there is the decrease in urinary frequency. So post or surgical procedures is usually manifested by paralytic ileus and urinary retention, and the condition is manifested by constipation and also by the decrease in urinary frequency. So for this neostigmine is given because this neostigmine or the reversible anticholinesterase drugs, what does they do? They will stimulate these receptors, muscarinic receptors that are present on the small intestine, as well as they will stimulate the muscles that is present on the urinary bladder, and they will stimulate them and will cause contraction of these muscles, and this will result in now the increase in defecation and increase in urinary frequency. And they can be also given in case of cobra bite. So cobra bite usually in different types of snake bite and cobra bite, which is very poisonous species of the snake. So here usually the specific anti-venom serum is required, but why these reversible anticholinesterase drugs are given? Because this cobra bite or this snake bite causes they do have this curator-like neurotoxin. So curator-like neurotoxin is the curate is skeletal muscle relaxants like D-tuberculin, which we discussed in last class. So curator has a new curator is skeletal muscle relaxant. They paralyzes the skeletal muscle, and you know the drugs that increases the skeletal muscle contraction are the cholinergic drug. And for this, neostigmine is given. So neostigmine stimulates the muscarinic receptors, stimulate the nicotinic receptors. So in the nicotinic receptors, it will stimulate the NM receptors that are present on the skeletal muscle and will reverse the condition, because this cobra bite consists of the curare neurotoxin, and this curare neurotoxin is the skeletal muscle relaxant. And we need to now contract the skeletal muscle because the relaxation has caused by this cobra bite. And for this, neostigmine is given, so it causes the contraction, it causes the stimulation of the muscarinic as well as the nicotinic receptors. In the nicotinic receptors, it will stimulate the NM receptors that are present in the skeletal muscle plate or neuromuscular junction and will cause the muscle contraction. And to ensure if the neostigmine dose has not been exceeded, so its antidote, that is the atropine, is being given. So atropine is usually given to know if there is any risk or if there is any higher doses of neostigmine is being given. And the uses of these reversible anticholinesterase drugs is in the treatment of the Alzheimer's disease. So we have already discussed this. So Alzheimer's disease is a senile dementia which occurs with the progressing age, and there is a loss of the cholinergic neurons, and cholinergic neurons is associated with the learning and memory process. So when there is decrease in the cholinergic neurons, so the patient ability to learn and memory has been decreased. And the drugs that are given in Alzheimer's disease include the rivastigmine, donepezil, galantamine, also the tecrine. So why these drugs are being given and why not physostigmine, neostigmine, etc.? Because this group of drugs, rivastigmine, donepezil, and galantamine, are cerebroselective. So cerebrum is the part of the CNS which is mainly associated with the learning and memory process. So when you give rivastigmine, donepezil, and galantamine, they won't have any effects on other system, like they won't have any effects on the skeletal muscle, they won't have any effect on the urinary bladder or the muscles of the GIT. So they are cerebroselective and can only act on the cerebrum. So this group of drugs are given. And why these drugs are given? Because these are the reversible anticholinesterase drug. They will inhibit the acetylcholinesterase enzyme. So inhibition of acetylcholinesterase enzyme means there won't be degradation of the acetylcholine. There will be increased amount of the now acetylcholine. Now this increased level of acetylcholine is associated with the increase in learning and memory process. So this cerebroselective drug like rivastigmine, donepezil, and galantamine are being used for the treatment of the Alzheimer's disease. So these were about the reversible cholinesterase inhibitors. So we are moving towards the irreversible cholinesterase inhibitors. So अहिले तिमीहरुको यो जुन हामीले यो Zoom-बाट क्लासेसहरु गर्छौं हैन, अहिले I think due to some security reason this chat has been disabled. That section has been disabled. अनि अर्को चाहिँ नि यो अरु पार्टिसिपेन्टहरु जुन होस्ट हुन पाउँछ हैन, बोल्न पाउँछ, अनम्युट हुन पाउँछ, त्यो पनि बन्द गरेको छ, because in some classes there were some offensive message अरु चाहिँ थर्ड पार्टी इन्भल्भ हुने, so proxy ID हरुबाट चाहिँ इनरोल हुने गर्दा त्यो चाहिँ नि कुनै कुनै क्लासेसमा देखिराखेको थियो. So त्यसले गर्दा चाहिँ नि यो चेट सेक्सनहरु इन डिसेबल गरेको छ. सिमिलरली यो पार्टिसिपेन्टहरु चाहिँ नि अनम्युट हुने अप्सन पनि डिसेबल गरेको छ आई थिंक हैन. So त्यसले गर्दाखेरि चाहिँ नि टु वे कम्युनिकेसनमा चाहिँ नि आई थिंक there will be some kind of के भन्ने हैन, त्यो टु वे कम्युनिकेसन हुन सक्दैन होला अहिले.
Ma'am, I think I'm audible to you. Ma'am, chat section मात्रै सरले त्यो डिसेबल गर्नु भएको छ. यो म्युट चाहिँ हामी हैन कुनै प्रब्लम छ भने हजुरसँग इन्टरेक्ट गर्न सक्छौं यो चाहिँ.
ए ओके फाइन ओके. चेट सेक्सन चाहिँ नि त्यसो भए डिसेबल गरेको छ. पार्टिसिपेन्टहरु त्यसो भए चाहिँ नि अनम्युट चाहिँ नि हुने अप्सन चाहिँ नि छ. ओके फाइन. सो इफ देयर इज इन्टरप्सन प्लिज लेट मी नो है.
स्योर म्याम. यस म्याम.
ओके थ्यांक यू. So अघिसम्म हामीले जति पनि डिस्कस गर्यौं हैन, so we discussed about the directly acting acting cholinergic drugs. We discussed about the indirectly acting cholinergic drugs. So directly acting भनेको चाहिँ नि, they will directly go and bind to different nicotinic or muscarinic or both the receptors and will exhibit it functions or actions. So जसमा चाहिँ नि हामीले चाहिँ acetylcholine पढ्यौं. So acetylcholine is prototype as well as then major neurotransmitter in case of cholinergic system or parasympathetic system. So pilocarpine पनि directly acting drugs मा पर्छ, जसमा चाहिँ pilocarpine को main use भनेको चाहिँ glaucoma मा हो, अर्को चाहिँ Sjogren's syndrome मा पनि हुन्छ हैन. So indirectly acting drugs मा हामीले चाहिँ नि, so indirectly acting drugs are also known as cholinesterase inhibitors. So why they are known as cholinesterase inhibitors, यो चाहिँ तिमीलाई राम्रोसँग थाहा हुनुपर्छ. मैले बारम्बार भनिराखेको पनि छु, because these are the group of drugs acetylcholinesterase enzyme that is responsible for degradation. भइसकेपछि त्यो enzyme के हुन्छ त, acetylcholine won't be metabolized, it won't be degraded, so there will be increased amount of the acetylcholine. Now this increased amount of the acetylcholine will go and bind for either of these receptors and will exhibit its functions or actions हैन. जसमा चाहिँ नि reversible छ, अर्को चाहिँ नि irreversible हामीले चाहिँ नि रिभर्सिबल गर्यौं हैन. जस्तो फाइजोस्टिग्मिन गर्यौं, it is antidote in case of atropine poisoning. न्यूरोस्टिग्मिन गर्यौं, it is antidote to D-tuberculin poisoning, and it is also the drug of choice in the treatment of the myasthenia gravis. Similarly, pyridostigmine is also the alternative drug that can be used in the treatment of the myasthenia gravis. Similarly, idurofonium is the shortest acting acetylcholinesterase enzyme inhibitors, so they is used in the diagnosis of the myasthenia gravis, or to differentiate whether the patient is suffering from the myasthenia gravis or the cholinergic crisis. Similarly, your tecrine, rivastigmine, donepezil, or galantamine, they are the cerebroselective cholinesterase inhibitors, reversible cholinesterase inhibitors, which are used in the treatment of the Alzheimer's disease. Earlier, हामीले गरेको भनेको चाहिँ नि यतिसम्म गरेको. So हामी चाहिँ नि अब we are moving towards the irreversible cholinesterase inhibitors. Okay. So you should be able to know what's the difference between this reversible and irreversible. So mechanism of action दुईटैको similar नै हो. They inhibit this acetylcholinesterase enzyme. So acetylcholinesterase enzyme inhibit गर्नु भनेको there will be increased level of the acetylcholine. So there will be increase in muscarinic effects. There will be increase in nicotinic manifestations. But so difference के हो भन्दाखेरि चाहिँ नि, so this reversible drugs will bind to this acetylcholinesterase enzyme reversibly, so bonds and weak huncha, whereas in this case irreversible ones, the bond between this irreversible cholinesterase inhibitors and acetylcholinesterase enzyme is very strong. So dissociation के हुन्छ भन्दाखेरि चाहिँ नि एकदमै गाह्रो हुन्छ. So duration of action will be also prolonged. So we are now moving towards this irreversible cholinesterase inhibitors. Okay. So irreversible indirect acting cholinergic agonist भनेको र irreversible anticholinesterase भनेको र irreversible cholinesterase inhibitors भनेको, they all are the same thing. Right? Please don't get confused. If question related to these subheadings are asked, like irreversible indirectly acting cholinergic agonist or irreversible anticholinesterase. So anticholinesterase भनेको के हो त, which will inhibit the acetylcholinesterase enzyme. So अर्को irreversible cholinesterase inhibitors, these all are the same thing. Okay. So why this is important? Because why these irreversible cholinesterase inhibitors are important? Because so यो पनि दुईटा parts मा divide भएको छ. So one is the phosphate and the other one is the carbamide. अर्को why this is important? Because यो organophosphorus poisoning भनेर हुन्छ हैन, which is very common and they are very much encountered in hospital in day-to-day basis. So daily नै कति number and कति number of organophosphorus poisoning को cases आउँछ. So it can be so mainly organophosphorus poisoning or suicidal purposes को लागि चाहिँ गरिराखेको हुन्छ, because this organophosphorus compounds are basically the insecticides and pesticides that are used during the farming procedures, right? So farming, agriculture हरूमा चाहिँ नि यो organophosphate compounds हरू एकदमै युज गरिराखेको हुन्छ. So they are used for suicidal purposes as well. अनि organophosphorus poisoning चाहिँ नि हस्पिटलमा एकदमै one of the very much encountered case हो है. So this is very important, and you should be you should be learning about the management of this organophosphate poisoning as well. So these organophosphorus compounds are powerful inhibitors of the acetylcholinesterase enzyme, and that binds to the enzyme by covalent bonds. And you know, covalent bond is the strongest bond present, and so mechanism of action. So organophosphorus compounds are powerful inhibitors of the acetylcholinesterase enzyme. So these organophosphorus compounds bind to this acetylcholinesterase enzyme with very strong bond, that is the covalent bond. So the dissociation of these acetylcholinesterase enzyme from organophosphorus compounds becomes difficult, and they will have the longer duration of action as well. And they are lipid soluble compounds. So lipid soluble compound, they can enter into various membranes of the body. So they can enter into the body by the eye or skin or respiratory system and the GIT. And organophosphorus compounds include insecticides like malathion and parathion. So यसमा पनि भनेको छ हैन. So यो ecothiophyte, malathion, parathion are all these insecticide and pesticides that are used in the agricultural process, है. अनि यो अर्को चाहिँ के भनेको छ भन्दा यो सेरिन, क्युबेन, सोमेन, these are the nerve gases. So nerve gases, so it can be insecticides or pesticides like malathion or parathion, or nerve gases like serin, cuben, tebune, and somen. So serin, cuben, and somen are the nerve gases. They are also known as the nerve agents. So they are the nuclear weapons and used for the mass destruction. And they were developed during the Second World War. These nerve gases or nerve agents, which are the chemical weapons used for the mass destruction. So they were developed during the Second World War, but not used. But अरू वारहरूमा चाहिँ युज चाहिँ नि भएको छ है यो नर्भ ग्यासेसहरू. अनि to even very low concentration of these nerve gases is very lethal, and death in any of these cases either it is due to the insecticide poisoning or insecticide poisoning of the nerve gases poisoning. So it occurs as a result of the respiratory paralysis. So patient is unable to breathe. So patient will suffer from asphyxia, and death of this patient occurs. So this is the picture showing the use of these insecticides and pesticides in agricultural process, and the use of this organophosphate compounds. So organophosphate compounds भने बित्तिकै यो insecticides पनि पर्छ, यो nerve gases पनि पर्छ है, don't get confused. And the use of these insecticides, pesticides mainly, the nerve gases are, they are not easily available. So lab ma matra ekdamai organized and highly के भन्छ एकदमै राम्रो ल्याबमा मात्र चाहिँ नि यो नर्भ ग्यासेसहरु चाहिँ नि इन्भेन्ट गरिन्छ, डिस्कभर गरिन्छ, प्रोड्युस गरिन्छ. But these insecticides can be found anywhere, हैन. So patient or person can go and buy from anywhere this insecticide and pesticide, and poisoning due to this insecticide is very common and usually encountered in hospital. So this is the picture showing the farmers using the insecticides and pesticides for agricultural process. So this is the mechanism of action. So this organophosphorus compound, so it acts similar way with the reversible acetylcholinesterase inhibitors. So they will inhibit this acetylcholine enzyme, but the action is irreversible one. So the bond is very strong. So dissociation of these compounds from the acetylcholinesterase enzyme becomes very difficult. So they will have the longer duration of action, and they are lethal as well. So there will be increase in level of the acetylcholine. So there will be inhibition of acetylcholinesterase enzyme irreversibly. That means there will be no degradation of the acetylcholine, and there will be increase in level of the acetylcholine. And now this increased level of the acetylcholine is going to have the excessive muscarinic and the nicotinic manifestation in the patient. So your organophosphorus poisoning, which is very common. So I think organophosphorus poisoning को clinical manifestation or के हुन्छ भन्दाखेरि त्यो चाहिँ नि याद हुनुपर्छ. So most of them we have already discussed, like, so they are the exaggeration of the muscarinic and nicotinic symptoms. Okay, so please remember what are the different muscarinic symptoms or what are the different nicotinic symptoms when cholinergic drugs, acetylcholine or its congeners are given. So the thing, clinical manifestations are the same thing. Okay, so the exaggeration of those muscarinic and nicotinic manifestations. So these agents cause excessive cholinergic stimulation. So it can be both a muscarinic manifestation and it can be nicotinic manifestation as well. So in the eye, there can be irritation of the eye. So I will request you to go back towards the different muscarinic and nicotinic manifestation that occurs by the use of acetylcholine or its congeners. So same thing नै हो है यहाँ चाहिँ they are the exaggeration of those manifestations. So irritation of the eye, because they are very corrosive compounds and there can be irritation of the eye and blurring of the vision can be there. So in the eye, there can be increase in lacrimation because there is the stimulation of the antheroreceptors present in the lacrimal gland, and so there would be excessive lacrimation. Similarly, myiasis will be there. So myiasis is the constriction of the pupil, and it results as a result of the contraction of the circular muscle or the sphincter pupillae in the iris of the muscle of iris. So can lead to the myiasis, that is the constriction of the pupil. And there can be spasm of accommodation as well, And in the salivary gland, so there will be stimulation of the antheroreceptors in the salivary gland that will increase the salivation, and there will be stimulation of the antheroreceptors that are present on the sweat gland, and there will be increased amount of sweating. Similarly, there will be increase in tracheobronchial secretions by stimulating the antheroreceptors that are present in the tracheobronchial tree, and there will be increase in stimulation of antheroreceptors that are present in the bronchioles of the lungs, and this can lead to the breathlessness or difficulty in the breathing of those particular patient. And there will be the colic. Colic is the increased amount of the contraction. So colic can occur in the stomach, in the intestinal tract and gastrointestinal tract, and can result in increased in defecation. And similarly, there will be increase in contraction of the antheroreceptors. There will be increase in contraction of the bladder muscle, that is a detrusor muscle, by the stimulation of the antheroreceptors that are present on the urinary bladder. And there will be increase in urinary frequency as well, so which can lead to the involuntary defecation and involuntary urination in those patients who are exposed to organophosphorus. And all these things, all these are the muscarinic symptoms, right? And most of these are due to the manifestation or the exaggeration of the antheroreceptor stimulation. Please try to remember where are the location of the M3 locations, in which part of the body M3 receptors are present, and what happens if this M3 receptors are stimulated. So these are the similar manifestation. And there will be the fall in BP, and fall in BP again occurs as a result of M3 receptor stimulation that are present on the blood vessels, and as a result there is an increase in nitric oxide production, and there will be the vasodilatation, and the vasodilatation means there will be the fall in BP. And bradycardia occurs as a result of the stimulation of M2 receptors that are present on the heart. So M2 receptors in the heart is stimulated, and there will be the decrease in heart rate. So this can result in bradycardia. And sometime there can be tachycardia as well, that is increase in the heart rate. So this fall in BP and bradycardia or tachycardia can lead to the vascular collapse. And those were the muscarinic manifestations. Now coming with the nicotinic manifestations. Nicotinic manifestations के हुन सक्छ होला? Please anyone answer. What happens if there is excessive nicotinic receptor stimulation?
Paralysis.
Paralysis of
Skeletal muscles.
So it is the weakness and paralysis of the skeletal muscle, but initially the contraction because it will, this acetyl increased amount of the acetylcholine will act on the NM receptors that are present on the muscle end plate or neuromuscular junction of the skeletal muscle and will cause the increase in contraction of those muscles. But with time, with prolonged exposure contraction this will lead to the flaccid paralysis and weakness of those skeletal muscle. So muscle fasciculation also, muscle fasciculation means increase in muscle contraction and further on, so this position now the muscle will be paralyzed and there will be the weakness of the muscle. And similarly, there will be respiratory paralysis as well. And this patient can go to seizures, patient can go to convulsions and unconsciousness, coma, and death can occur. And death of the patient who are exposed to organophosphorus compounds usually occurs as a result of the respiratory failure. So respiratory failure is stimulation of the M2 receptors that are present on the bronchioles of the lungs, and there will be the bronchoconstriction or the bronchospasm. Patient is unable to breathe. There will be the asphyxia, and patient will go to the respiratory failure, and patient will go to death. So death due to this OP poisoning usually occurs as a result of the respiratory failure. So we are moving towards the treatment of the organophosphorus poisoning, which is very important as well. And sabai poisoning ko chaine general principles is the same thing. So I mean OP poisoning masam. So general principles of the OP poisoning, general principles in the treatment of the OP poisoning will be also there, will follow the same thing. So decontamination should be there. So patient who are exposed to OP poisoning, so this should be decontaminated, so clothes should be removed and they should be thoroughly washed, and flushing should be there. So termination of the further exposure to the poison should be there, and patients should be exposed to fresh air and wash because they are lipid soluble compound, they can enter into any membranes of the body. So wash the skin and mucous membrane, washing of skin and mucous membranes should be done with soap and water, and in order to avoid or inhibit the absorption of the further compound, OP compounds into the stomach, so gastric lavage should be done. So like the gastric lavage is usually done with the activated charcoal. So in gastric lavage, usually a tube that is a nasogastric tube from the nose or the orogastric tube from the oral cavity is passed and it is passed up to the stomach, and from that tube, so activated charcoal is given. And what does this activated charcoal do is they will inhibit the further absorption of the compound, that is the OP compounds or any other compounds in case of other poisoning. So here it is the OP compound, so activated charcoal is given via the tube, and it will inhibit the absorption of the unabsorbed compounds, and these unabsorbed compounds are moved via the another tube. So gastric lavage is mandatory in most of the poisoning cases. And maintain the patent airway because there is a bronchospasm and or bronchoconstriction due to OP poisoning. So patient will have difficulty in breathing. There will be the asphyxia, and so sometimes artificial respiration or breathing may be needed. So in that case, maintenance of the patent airway should be done, and supportive measures should be done, as for example, maintenance of BP, because the BP has been decreased here because of the vasodilatation due to the production of the nitric oxide. So maintenance of BP should be done with the help of drugs like adrenaline. So hydration should be done. So why hydration is mandatory in OP poisoning? Can anyone answer? Why hydration is required? Yes, anyone?
Over salivation, diarrhea, over urination occur during the poisoning, so over hydration.
Increase in can you repeat once again?
Over salivation, yes. Diarrhea and urination occur during the OP poisoning, so while treating the OP poisoning, we require hydration.
So there is diarrhea, there is increase in urinary frequency. Okay, fine. सो त्यो पनि हो हैन त्यो भन्दा पनि मोर इम्पोर्टेन्ट चाहिँ नि सो पेशेन्ट हेज अन्डरगन एक्सेसिभ स्वेटिङ है स्वेटिङले चाहिँ नि मोर अमाउन्ट अफ फ्लुइड अपार्ट फ्रम द डायरिया एन्ड द इन्क्रिज इन युरिनरी फ्रिक्वेन्सी स्वेटिङले पनि के हुन्छ भन्दाखेरि चाहिँ नि there will be decrease in the body fluid, so constant hydration is required, so it should be supplied, so IV fluid should be supplied, and control of convulsions should be there, so seizures are आउँछ किनभने चाहिँ नि there is the stimulation of the NM receptors in the skeletal muscle, so convulsions or seizures or contraction of skeletal muscle is increased, so that should be treated with the use of anticonvulsant drug, that is the diazepam. So supportive measures are पनि चाहिन्छ हैन. And now we are moving towards the specific treatment of OP poisoning. So usually you case यति चाहिँ नि usually चाहिँ नि अरु poisoning को cases हरुमा पनि these are the general principles that is applied. So we are moving towards a specific management of this OP poisoning. Okay. So specific antidotes. So specific antidotes, there are two specific antidotes. One is the atropine. So atropine is the anticholinergic drug, and the other antidote is known as the cholinesterase reactivators. Okay, so there are two specific antidotes, please remember. So one is the atropine, which is a anticholinergic drug, and the other antidote is the cholinesterase reactivator. So we'll go one by one over here. So specific antidotes, so one of them is the atropine, and you know this, and please don't get confused right now. So you know this atropine, so atropine हामी or सायद अर्को क्लासमा पढ्छौँ, anticholinergic drug हामीले अर्को क्लासमा स्टार्ट गर्छौँ होला. So atropine is the prototype drug for the anticholinergic drug. जस्तो this यो cholinergic agent drug or cholinergic system को लागि चाहिँ नि acetylcholine is a prototype drug. Similarly anticholinergic drug को लागि चाहिँ नि atropine हो है. So atropine is anticholinergic drug. Okay. अनि स्टुडेन्टहरु युजुअली केमा कन्फ्युज हुन्छ भन्दाखेरि सो स्टुडेन्टहरुले अर्को के भन्छ भन्दाखेरि चाहिँ नि यो छ नि यो पाइजोस्टिगमिन, नियोस्टिगमिन, पाइरोस्टिगमिन और यो इकोथायोफेट, मालाथियोन, यो कार्बोरिल प्रोपोक्सरहरु हैन, यसलाई पनि एन्टिकोलिनर्जिक ड्रग भनिन्छ के. बट यो एन्टिकोलिनर्जिक ड्रग होइन है. प्लिज रिमेम्बर दिस पाइजोस्टिगमिन, नियोस्टिगमिन और organophosphatic compounds like serintubin or the icothiophate, they are not anticholinergic drug. What are they? They are indirectly acting cholinesterase inhibitors, or they or के पनि भनिन्छ भन्दाखेरि यिनीहरुलाई चाहिँ नि indirectly acting anticholinesterase पनि भन्छ है. Indirectly acting anticholinesterase, but they are not anticholinergic drug. So यो के हो त, यो cholinergic drug नै हो है. So cholinergic drug को कुन क्लासिफिकेसन हो भन्दाखेरि चाहिँ नि indirectly acting cholinesterase inhibitors or indirectly acting anticholinesterase हो है. So स्टुडेन्टहरु एकदमै कन्फ्युज हुन्छ है. As for example, एउटा if a student comes to Viva and I ask a question, name a anticholinergic drug भन्दाखेरि चाहिँ नि atropine कसैले भन्छ हैन, कसैले चाहिँ के भन्छ भन्दाखेरि चाहिँ नि so पाइजोस्टिगमिन, नियोस्टिगमिन और यो सेरिन्ट्युबिन, इकोथायोफेट पनि भनिराखेको हुन्छ. These are not anticholinergic drugs. They are the cholinergic drugs that falls under the indirectly acting cholinesterase inhibitors or indirectly acting anticholinesterase. So your cholinesterase inhibitors ra anticholinesterase are same thing. Please don't get confused. So cholinesterase inhibitors ra / anticholinesterase gare pani huncha. So both mimics the same thing, but they are not anticholinergic drug. Okay. So okay, we were on the specific antidotes in case of OP poisoning. So since these organophosphorus compounds, so organophosphorus compounds ma ke huncha poisoning ko cases ma ke huncha bhandakiri there is excessive muscarinic manifestation, there is excessive nicotinic manifestation. So we need to control those excessive muscarinic as well as the excessive nicotinic manifestation हैन. So हामीले के दिनु पर्यो त, a drug that controls these excessive muscarinic and excessive nicotinic effects. So for that we are giving the antidotes. So you say general management भयो, अब specific management मा चाहिँ we need to control the excessive muscarinic and the nicotinic manifestation. And atropine, so excessive muscarinic manifestation हुन्छ, nicotinic manifestation पनि excessively भइराखेको हुन्छ. So however the anticholinergic drug, that is the atropine, so it is able to counteract or it is able to reverse only the muscarinic symptoms, right? So it is an atropine, although it is an anticholinergic drug, so it is able to reverse or it is able to counteract only the muscarinic symptoms. It's not able to counteract or it's not able to reverse the nicotinic symptoms. Please remember that. So it is highly effective in counteracting the muscarinic symptoms. So agi jati pani yo irritation of the eye bhairaheko थियो, constriction of the pupil bhairaheko, increase in bronchial secretion, similarly excessive sweating, lacrimation haru, increase in defecation, urination haru bhairaheko थियो. So they are able to counteract those muscarinic symptoms. So they don't reverse the peripheral muscle paralysis, which is a nicotinic symptom. So nicotinic action. So nicotinic action is usually skeletal muscle paralysis or the skeletal muscle weakness or garirakheko hunthyo. So atropine is not able to counteract or atropine is not able to reverse those nicotinic symptoms like skeletal muscle paralysis and weakness. Okay. So यो सबैले बुझेको कुरा हो. So acetylcholine चाहिँ नि muscarinic receptors मा गएर bind गर्छ. Here is a subtype of M2 receptor. So acetylcholine यो muscarinic receptor मा bind भइराखेको छ. So muscarinic symptom मा bind भइसकेपछि चाहिँ नि it will manifest different muscarinic actions, right? So अब atropine ले के गर्छ भन्दाखेरि चाहिँ नि अब atropine is competitive antagonist of the acetylcholine. So now atropine अब acetylcholine जुन चाहिँ अघि receptor मा आएर बसिराखेको थियो, अब चाहिँ के गर्छ त atropine चाहिँ being a competitive antagonist, it will replace this acetylcholine and अब चाहिँ नि atropine गएर बस्छ यो receptor मा. अब acetylcholine ले जुन excessive muscarinic manifestation हरु गरिराखेको थियो, अब त्यसलाई के गर्ने भयो त त्यो हुन पाएन. The condition will be reversed or the condition will be the counteracted. Okay. And for this prompt atropine need to be given, and so what is the dose? It is 2 mg intravenously. So atropine dinu paryo, so 2 mg, the dose is 2 mg and mode of administration is intravenously, and it should be repeated every 10 minutes until dryness of mouth or other signs of atropinization occurs. So के भनेको मतलब के भन्दाखेरि चाहिँ so when OP poisoning is there, so OP poisoning को excessive muscarinic manifestation भनेको चाहिँ there is increase in salivation, right? So atropine दिएपछि के हुनु पर्यो, opposite function हुनु पर्यो नि हैन. So OP poisoning ले चाहिँ नि excessive salivation गरिराखेको छ भने, so atropine being a competitive antagonist अब के गर्नु पर्यो, उल्टो effect देखाउनु पर्यो, that is the dryness of the mouth should be there. So कति बेलासम्म repeat गर्नु पर्यो until dryness of the mouth is there or other signs of atropinization occurs. अब other signs of atropinization मा के हुन सक्छ भन्दाखेरि चाहिँ नि अब OP poisoning हुँदाखेरि चाहिँ नि as for example in the eye चाहिँ नि constriction of the pupil or myiasis भयो. अब atropine दिएपछि के हुनु पर्यो, mydriasis or the dilatation of the pupil हुनु पर्यो. So the opposite effect should be there. So the dose is 2 mg IV. And it should be repeated every 10 minutes until dryness of the mouth occurs or other signs of atropinization like mydriasis occurs. And treatment should be continued with the maintenance doses, and it may be required for 1 to 2 weeks as well. You know, यो जुन irreversible anticholinesterase छ हैन, त्यसको duration of action चाहिँ when they are bound to this acetylcholinesterase enzyme, so the bones are एकदमै strong हुन्छ, जसले गर्दा चाहिँ नि easily disassociate हुन पाउँदैन, remove हुन पाउँदैन, जसले गर्दा चाहिँ नि त्यो symptoms हरु muscarinic symptoms, nicotinic symptoms हरु चाहिँ long duration सम्म देख्न सकिन्छ. And so sometimes maintenance doses can be required for 1 to 2 weeks as well. Okay. And coming to another specific antidote, जसमा चाहिँ नि we call it as cholinesterase reactivators. So here is a drug like pralidoxime or drug like obidoxime पनि छ हैन. So but हामीले चाहिँ नि pralidoxime कै example दिएर पढाउँछौं. So another group of drugs, so which is used as specific antidote to this OP poisoning includes the cholinesterase reactivators. So main यो cholinesterase यो OP poisoning मा चाहिँ नि के भइराखेको हुन्छ भन्दाखेरि चाहिँ नि there is the inhibition of the acetylcholinesterase enzyme, right? So they are inhibited irreversibly, and the bond is very strong. So जुन चाहिँ डिसोसिएसन गर्न गाह्रो हुन्छ. अब हामीले चाहिने कुन ड्रग दिनु पर्यो भन्दाखेरि चाहिने the group of drug that will now reactivate the acetylcholinesterase enzyme, because in opioid poisoning, so acetylcholinesterase enzymeहरू के भइराखेको हुन्छ त, they are inhibited, so there will be no degradation of the acetylcholine, so increased level of acetylcholine भइराखेको छ, जसले चाहिँ different muscarinic and nicotinic symptoms गरिराखेको छ. So we need so another group of drugs are question. So we need to give a drug so which will now activate this inhibited acetylcholinesterase enzyme. So अब acetylcholinesterase enzyme चाहिँ reactivate भइसकेपछि के हुन्छ भन्दाखेरि चाहिँ जुन अघि excessive acetylcholinesterase molecule compoundहरू चाहिँ production भइराखेको थियो, अब त्यसलाई के गर्छ त, now this acetylcholinesterase reactivators ले के गर्छ त, so the acetylcholinesterase enzyme लाई reactivate गराइदिन्छ अनि त्यसपछि चाहिँ now it will able to degrade or metabolize those excessive acetylcholine compounds. I hope you are following me, है. And अघि जुन एट्रोपीले चाहिँ नि muscarinic symptoms like मात्र counteract गरेको थियो, reverse गरिराखेको थियो. अब cholinesterase reactivators ले चाहिँ नि के गर्छ भन्दाखेरि nicotinic symptoms लाई चाहिँ नि counteract or reverse गर्छ. Okay. So to relieve the neuromuscular blockade that was caused by the nicotinic action, so pralidoxime is given. So pralidoxime is acetylcholinesterase reactivator. So cholinesterase reactivators र acetylcholinesterase reactivators भनेको चाहिँ नि it is the same thing, okay? And it should be given as soon as possible. So this pralidoxime or cholinesterase reactivators should be given as soon as possible. Because if too much of time passes after the opioid poisoning occurs, the poison bond becomes too strong. That is, the opioid poisoning bond with the acetylcholinesterase enzymes become too strong for pralidoxime to work. Okay, so your pralidoxime or एकदमै as soon as possible दिनु पर्यो, because time चाहिँ जति increase भयो के हुन्छ त भन्दाखेरि यो pralidoxime ले चाहिँ काम गर्दैन. So it should be given as soon as possible. So portion of this will be covering in next class. To have a brief idea. So your pralidoxime कसरी काम गर्छ त्यो भन्दा अगाडि you should be knowing what are the different sites on the acetylcholinesterase enzyme. Okay, so this is a figure showing the acetylcholinesterase enzyme. So you know this acetylcholinesterase enzyme is responsible for degradation for the metabolism of the acetylcholine. So acetylcholinesterase enzyme, they have got two sites. You can see here two sites. One is the anionic site. The other one is the steric site, which is also known as the steretic site. So two sites on acetylcholinesterase enzyme, anionic site and steretic site. So acetylcholine molecule, it is a quaternary ammonium compound. It has got the positive charge. So anionic site vaneko, they will have obviously the negative charge. So acetylcholine molecule or the compound or the neurotransmitter or the drug or the agent, so they do have the positive charge. They are quaternary ammonium compounds. So the positive charge and they are attracted towards this anionic site, okay, because they do have the negatively charged particle. So because they are the negatively charged site. And अर्को यो स्टेरेटिक साइटमा एउटा चाहिँ serine residues भनेर हुन्छ, in which they have got the hydroxyl group. Okay, so acetylcholine molecule, so it binds with because they have the positively charged ion, so they bind towards the anionic site which carries the negative charge. And there is another site which is known as the steretic site, and there is a serine part in this steretic site which is called the hydroxyl ion. यो जुन यो CO ketone group छ यो चाहिँ नै hydroxyl group सँग चाहिँ नै bind हुन्छ. So now this acetylcholine, after binding to this acetylcholine esterase, is now then degraded into its two parts. So हामीले जुन acetic acid र choline भनेर भन्थ्यौ नि हैन last time मा. So acetic acid or choline or acetate or choline. So now after binding of acetylcholine to this acetylcholine esterase compound, so they are degraded they are metabolized into two compounds, that is the acetic acid and the choline. Okay. So I think we'll be covering rest of the class in next class, and in next class we'll be starting with the anticholinergic drug as well. And I request you to go through the OP poisoning and the treatment of OP poisoning, right? So that it will be easier for you to understand. And OP poisoning, treatment of OP poisoning are important as your exam point of view as well. And the clinical side so it is more easier for you to interpret. Okay. So any question for today's class? Any question?
No, ma'am.
So next class ma hunदाखेरि OP poisoning र anticholinergic drugs पढेर आउनु है. अनि त्यसपछि CRD चाहिने एभ्री क्लासको चाहिँ अटेन्डेन्स चाहिँ मेन्टेन गर्नु. अनि एज सेड अर्लियर प्लिज गो थ्रु योर बुक्स. अनि त्यसपछि के यो स्टडी मटेरियल चाहियो भने हो. स्टडी मटेरियल सो यो म एउटा च्याप्टर चाहिँ सकिएपछि सो कोलिनर्जिक ड्रग एटलिस्ट सकिएपछि आई विल प्रोवाइड यु. ओके. Okay, if there is no question, I'll end here for today. Thank you.